I'm Hunter Spencer. I'm from OHSU here in Portland, and I really liked how everyone shared their story. I like how you shared your story. I'm a family member of a person who used to use drugs, and I feel so lucky that my little sister like didn't die of an overdose. And I really just want to make sure that we can keep all the folks that we know that use drugs, we can keep them alive long enough, and keep them healthy enough so that they can get better and have happy outcomes like my family's had. So that's how I come to this type of work. And a big part of keeping folks healthy is not letting them get severe illness from hepatitis C and treating Hep C. So that's what we're doing. Good. So we're going to talk about briefly. Everybody knows about Hep C, so breeze over that. But you can't have a slideshow without a background. We'll talk about the Oregon Health Tele-Hep C trial, which we talked about last year, and you've probably heard about. But we have some new secondary outcome data to share as well, which is cool. And then a brief update to the qualitative data from that study, and then updating you on peer-assisted telehealth, telemedicine for hepatitis C and syphilis, or PAS, which is the real-world implementation of Oregon Health. So go ahead. Just briefly, we received, and many of us individually received NIH funding, but obviously don't speak on behalf of the government. So that would be crazy. So obviously Hep C problem we're all aware of. The way it impacts Oregon is so kind of overwhelming. It's like hard to focus on it up too close. You got to take a step back and just be astounded by how it's impacted us here in Oregon. And the first thing we started with as a sort of research group was partnering with community-based organizations in rural areas to do peer harm reduction. And during that harm reduction, part of it obviously was Hep C testing. And we noticed that of all the people we tested, 50% of them had Hep C antibodies, which was wild. And we were only doing point of care testing. So we didn't really know if they actually had Hep C or not. But we knew that of the 50% who had Hep C antibodies, only 5% of those people had ever gotten treatment. So we knew that there was like basically a ton of people with Hep C that was just totally ignored in these rural areas. And so from there, we really responded to the needs of the peers, which the peers were like banging their heads against the wall trying to get people Hep C treatment, and it was almost impossible to do. And so we came up with a solution to offer easy to access Hep C treatment. And that's what we did after from there. Just obviously the interplay between substance use disorders and Hep C in Oregon, and particularly in rural Oregon, is kind of up and up. And as the younger kind of phase of the biphasic curve of people who have Hep C grows, the amount of people who have Hep C related to substance use disorders grows as well. That's who we're really targeting with this type of work. Sorry. Great. So this is a model that you may have heard about before, hopefully. But just to refresh you, we have peer-assisted telemedicine. That's the whole thing. So the peers are right in the center, and the peers and their peers, the clients, they form this dyad, and everything sort of radiates out from them. It's not a spoken hub and spoke model. It's a spoken hub model. Like everything's around the hub of the peers and the clients. And when I mean everything, what I mean by that is that the peers help folks kind of do everything you would need to do to get Hep C treatment. So that includes accessing resources like harm reduction and basic needs, basic survival needs in rural areas. It means accessing services like testing and a whole bunch of modalities, point of care, dried blood spot, partnering with labs to find out who the nicest phlebotomists are so we can have people have a good experience with phlebotomy. It also means partnering up their peers with the providers. So me and 3 of my colleagues in Portland were available for on-call appointments every afternoon of the week. And we know that a lot of our patients don't have their own phone, for example. So the peers bring their own device from their work or their own laptop, and they bring that to folks where they're physically at. And it also means navigating complicated healthcare systems like specialty pharmacies, which are a huge headache. And the peers have gotten really good at navigating and mitigating these, what would otherwise be really crippling barriers. So that's how the system sort of works. Go ahead. And this is, or you can skip this one. I just put it in case you're looking at the slides at a later date. It explains the previous slide. So we did an experiment to see if that whole picture, that whole diagram that I showed you, if it actually works or not. And we compared basically that whole system, that whole diagram I showed you, we compared it to what we called enhanced usual care. So it was usual care, which meant getting care from a local doctor in rural Oregon, but enhanced by peer navigation. So even these people had peers on their side. The difference was that in the intervention arm, people had peer-assisted telemedicine, our full kind of scale intervention. This is who we recruited. We recruited 203 people. They were mostly the types of folks you would demographically you would expect to find in rural Oregon. The houselessness rate was exceedingly high. We recruited 69.5% of folks who were houseless, which is one, crazy in a clinical trial, and two, just an unbelievable reality that our patients are facing. And you can see, here, you don't even really have to comment on the drug use pattern. When I present this type of stuff elsewhere, people are stunned at how much methamphetamine use there is compared to opiate use, but we're used to that here in Oregon. So 203 people, this is who they were. And this is what happened. This is the main outcome. Basically, it's really easy to get Hep C treatment and cure if you use peer-assisted telemedicine, and it's almost impossible if you don't. So 85% of people who are randomized to telemedicine, peer-assisted telemedicine or tele-Hep C, 85% of them had started Hep C treatment in 6 months versus only 13% of people who tried to get peer-assisted navigation to usual care. And 63% of people in tele-Hep C were cured versus only 16% on the other side. So obviously this is an incredible finding. We were astonished and really pleased. This paper was just published with the illustrious Ann Thomas as a co-author just last week. So we're really happy, really happy to get this knowledge out there because it's an insane finding. Scientifically, you almost never see such big effects like this. So we've got some secondary outcomes, which are brand new on the next couple slides. Here's one of them. It turns out when you give people access to tele-Hep C, they will inject drugs less. And this is independent actually of whether or not they start Hep C treatment or whether or not they complete Hep C treatment probably. It really just matters that they were connected to tele-Hep C. And I think that probably illustrates the fact that people who are connected to tele-Hep C or randomized to tele-Hep C were a little bit more tied in with their peer than folks who were randomized to the peer-assisted usual care. Even though they both had peers, the peers were a little bit more integral in the tele-Hep C arm. We had some evidence for that because when we looked at the rate in a secondary analysis that's published there, when we looked at the rate of injection drug use, it was lower the more you had talked to a peer. So the more you worked with a peer, the less likely you were to inject drugs. So injection drug use decreases due to tele-Hep C. Next slide. Similarly, injection equipment sharing, high risk behavior for acquiring Hep C or other viral infections, and that decreases with more peer enrollment. This one actually didn't decrease by randomized arm, it only decreased by peer interactions. So more evidence that the peer-assisted telemedicine, it's really like a capital peer. It's really, really heavily weighted on the peer. The peers are really central. And next slide there. So then this analysis is really interesting. We had 70% homeless folks. There's a lot of evidence that homeless folks get worse Hep C outcomes. They're less likely to be treated for Hep C and they're less likely to get cured for Hep C. And actually, it turns out tele-Hep C is even more effective in homeless people than it is in all comers or in non-homeless people. So the relative risk for Hep C cure was like 6 for homeless folks versus only like 3 in homed folks. So it was really like a 3 times increase in it's effective in both, but it's even more effective in homeless people. That could have been for a lot of reasons. One, we did it during COVID. So maybe everybody was so like keyed up on telemedicine that they just really wanted to engage, or they felt like they couldn't get any help otherwise. But it also could mean that just houseless folks were just more dependent on interacting with the peer for basic survival needs. So that kept them kind of retained and so forth. But anyway, I'm not, those are probably the best explanations, but it's an amazing finding. There's not very many interventions that work better for folks who are not housed. And hopefully we'll get that published soon. Here's some updated qualitative interviews. Basically, folks in rural Oregon really liked the intervention. We had seen that in the earliest qualitative stuff. And you can go to the next slide. We did 34 interviews, so it's a good amount. The main things that had emerged, which we knew on the earliest kind of findings, is that the role of peer facilitation is really critical. The clinician sensitivity is really critical. So just not being a jerk is really critical. And then the elements of the model itself, like the actual nuts and bolts of how we help people get labs and how we pre-ordered the labs and how we had walk-in visits, like virtual walk-in visits, how we had all those elements, those were important too. And we've got a paper coming out soon that's going to describe all this qualitative data in a lot more detail, but those are the three main takeaways. Go to the next slide. This is something that we picked up on kind of later as we were looking at the qualitative. And to me, it's really incredible. What we found is a lot of people using language that described getting Hep C treatment as like a first step in this kind of journey towards a lot better health or a lot better just life. And it was really exciting to see that emerge because I'm a primary care doctor by training, so it feels good to believe that you can like help somebody with one little thing and then it'll make their whole life better. I think that's that was really exciting to me. So people describe it as making steps, making changes on steps on a path. And remember, these are folks who were mostly they were currently using, they weren't otherwise really looking for engagement in services. So their first thing that they did, their first healthcare success was Hep C treatment. And then that led to harm reduction. And then that led to other life changes that were bigger and even more important. We had folks, Joanna has a great story. We have folks that, kind of went through the program and then they have an extended period of abstinence or like at least much more controlled use, much less harmful use. And then that leads to having enough stability that they're able to get jobs. And then now they have permanent housing. And it's just like incredible stories have kind of emerged. And that's been really exciting. Okay, next slide. Here's some quotes that illustrate this idea of completing steps along a path. I just kind of quit shooting up other drugs and everything like that. So I guess it's one thing at a time. Well, I intend to change my whole life, and I just figured it was a good way to start. I think that's a really good point. Like Hep C treatment is super easy compared to so many other things that you would have to do to make your life a lot better. So you might as well start with the easiest one. If you don't take interferon. Yeah. Yeah. Yeah, it's like a miracle of the modern age, that we can have a treatment that's so easy compared to how everything else used to be. And then the last one here, I was afraid I was never going to be able to quit drugs. Things are looking up since they told me that I've gotten rid of Hep C and stuff. I'm starting to pull a little bit more strength out of things looking up like that. And I think we can really make a huge change in people's actual lives, not just their health or not just a certain disease. Great, next slide. So people talking about steps along a path, how fantastic. We have PAS. PAS is peer-assisted telemedicine for hepatitis C and syphilis. And we started this as an implementation kind of arm as the trial was ongoing. We actually got funding from OHA to implement it before we even finished enrollment. And so we had a lot of really promising early data. Obviously, the intervention was unlikely to harm anybody. And it was composed of other evidence-based interventions. So it made sense to implement it really early, and that's what we've done. So I can show you our updated kind of numbers and figures here. So we've expanded all over the state. We've trained folks in 18 counties in the state. And then we've got people trained and they've reached a treatment initiation. So they've actually got somebody all the way through to treatment initiation. So they've screened people and they found positives and they linked them to care and then the meds got mailed out to the right spot. We've got people trained and treatment initiated in 14 counties. So the 14 counties or the 16 counties at 14 sites, those are all the orange ones, which is a huge landmass. Like that's an incredible amount of the state that we're covering. And then the ones that we've trained people, but we just haven't got anybody through to treatment initiation quite yet, those are in blue. So you can see we focus on the rural areas. And yeah, I think I'm really proud of that. I'm really grateful to all the peers there. Tons of buy-in, we don't compensate peers specifically within paths. They're compensated otherwise by the harm reduction agencies that they work for. Our selling point to the peers is that part of their job is to do screening for hepatitis C and healthcare navigation. And you can do it the hard way or you can do it the paths way. And so we want to, our sell is that we can make life way easier for peers by giving them a really easy option for getting people connected to paths, and they can check that off of their list and check that off of their clients can check it off of their own list. So this is what we've done. We've got a ton of labs in the last year. So we're up to 838 labs that we've received. These are folks who either screened positive or they just told us they thought they had Hep C because not everybody can get to a point of care Hep C test. So we 838 labs received, 273 people diagnosed with hepatitis C. Of those 273, we've got 205 of them linked to care already. So that's a telemedicine visit with the providers up here in Portland. And then of the 205, we've got 178 of those folks initiated on treatment. 95 have completed treatment so far. And we had a huge wave of SVR12s coming back last week. We had 6 SVR12s last week, which was incredible because it was a holiday. And so that bumped us up to 85 cures. It was perfect timing. I don't know. Kelly is probably. So these numbers are kind of rough. We're going back and doing like a more detailed analysis so we can look at like predictors of advancing to the next step in the care cascade. But so they're a little bit rough, but it's what we got right now. And I think those 85 people are really folks that were unlikely to get cured otherwise, or unlikely to even get diagnosed otherwise. So it's an important number, even though that's where we're at. So I think one more slide. Oh, here's another thing. We made a website, so that's great. If you want to get technical assistance or join us or talk to us, that's an easy way to do it. The QR code, or that's our website, peerpathstohealth.org. And I'm really excited about this as a way of kind of reaching out to folks. Next slide. And yeah, thanks especially to the patients from the study. Thanks to all the peers and all the funders and all the other collaborators, and especially the ones in this room. So thanks a lot.